Transfusion-related acute lung injury is the serious complication of transfusion of blood products that is characterized by the rapid onset of excess fluid in the lungs. It is estimated to occur in 1 in 3,000 to 1 in 5,000 transfusion of plasma-containing products. Transfusion-related acute lung injury is the leading reported cause of death related to transfusion. All plasma-containing blood components and the plasma protein products have been implicated in transfusion-related acute lung injury. Despite the very small amount of plasma contained in packed RBC, this component is associated with the largest number of reported cases of transfusion-related acute lung injury because of frequent and multiple amount of transfusion is mainly this component or red blood cell. The most widely accepted hypothesis suggests that transfusion-related acute lung injury is the result of at least two independent clinical events. The first relates to the clinical condition of the patient that causes activation of the pulmonary endothelium, such as active infection, history of cytokine administration, surgery, severe burn injury, and the like. This leads to the sequestration of primed neutrophils to the activated pulmonary endothelium. The second event is the infusion of either donor-derived anti-human leukocyte antigen or anti-human neutrophil antigen antibodies directed against antigens on the neutrophil surface and or biological response modifier that activate this adherent and functionally hyperactive neutrophils. Whether activated by antibodies or by some other modifier, this activation causes neutrophil-mediated endothelial damage and capillary leak. This second mechanism is currently most widely accepted one. The activation of recipient neutrophils through donor-derived anti-human leukocyte antigen or human neutrophil antigen antibodies is often referred to as immune transfusion-related lung injury. The term non-immune transfusion-related acute lung injury is used to describe cases where soluble biological response modifiers in the transfused components are felt to be the causative agent in the absence of donor-derived antibodies. When we came to sign the symptoms of transfusion-related lung injury, the typical presentation of transfusion-related lung injury is the sudden development of shortness of breath, severe hypoxemia, low blood pressure, and the fever that develops within 6 hours after transfusion. And usually this resolves in supportive care within 48 to 96 hours. Although low blood pressure is considered one of the important signs for diagnosing transfusion-related acute lung injury, in some cases high blood pressure can occur. Pulmonary crackles might present without signs of congestive heart failure or volume overload, but most of the time chest is clear. Delayed transfusion-related acute lung injury occurs 6 to 7 hours after transfusion completion. This type or the delayed type is associated with high rate of mortality. Chest imaging should show clear evidence of bilateral pulmonary edema unassociated with heart failure or non-cardiogenic pulmonary edema. This includes bilateral patch infiltrates, which may rapidly progress to complete whiteout, indistinguishable from acute respiratory distress syndrome. Physiologic findings include acute hypoxemia with normal cardiac function on echocardiography. Once we diagnose transfusion-related acute lung injury, the mainstay of therapy is supportive care. Oxygen supplementation is needed in all patients with transfusion-related acute lung injury, and around 70% of patients require aggressive respiratory support. To support blood pressure, intravenous administration of fluids as well as vasopressors are essential. In treating transfusion-related acute lung injury, diuretics are to be avoided. Although they are indicated in the management of transfusion-associated circulatory overload, diuretics is not used in transfusion-related acute lung injury, unlike that of ARDS. Corticosteroids can be beneficial in critical patients with transfusion-related acute lung injury. Transfusion-related acute lung injury is associated with high morbidity and the majority of patients require ventilatory support. However, with supportive care, the lung injury is generally transient, with oxygen levels returning to pre-transfusion levels within 48 to 96 hours, and the chest X-ray returning to normal within 96 hours. But some patients are slower to recover and may remain hypoxic with persistent pulmonary infiltrate for several days. Thank you for watching.